Okay, so I just wanted to do this little voiceover PowerPoint so that uh, just as a review for Unit 5, 6, since we won't have any time to do it in person. So we have the patient with constipation and burning in her upper abdomen, taking Mylanta. So what else do we need to know um, about this person? One of the things that we need to know is what is her definition of constipation? Constipation really is dry, hard, difficult to pass stools. It isn't necessarily just a delay. So some people will say, I'm constipated because they're used to going every day and for some reason they didn't go today. So that's not necessarily constipation. We already know she didn't change her diet and she seems to have adequate input. So what else might have changed? Well, maybe her activity changed. Her stress level has changed. So these are all things that we might want to ask. Also, what has she done about the constipation? We also need to get some more medical history because of her report of taking the Mylanta. So we might might want to know if she has any history of kidney disease, heart disease, or hypertension, because a lot of over-the-counter medications for heartburn have sodium, magnesium, aluminum, and these can all be contraindicated. Obviously, sodium is contraindicated with someone with heart failure or hypertension. Aluminum is excreted by the kidneys, so if they have kidney disease, then obviously that's going to build up, and the same way with the magnesium. We want to know what her stools look like. Is she having any emesis? Is she passing gas? Because if she's not even passing gas, then that may be a whole different issue than just constipation. So these are all things that we would want to look at. So these assessments are important because the risk of toxicity, like I mentioned, of the magnesium or the aluminum, if she has renal disease, the sodium is going to increase her blood pressure and exacerbate the heart failure. We also want to look at any bleeding risk. If the stools are dark and tarry, we need to address, a whole different issue than just treating the constipation. So the active ingredients in Mylanta are aluminum hydroxide and magnesium hydroxide. It's important to understand that all of these medications that that are antacids, like Mylanta, Tums, different things like that, reduce the acidity. They neutralize the acid. They don't alter the production of the acid, which is why they have to be taken so frequently. When a patient takes an overdose of magnesium, then that can cause diarrhea. An overdose of aluminum and calcium can cause constipation. So she's taking this Mylanta numerous times a day, and that may be contributing to her constipation. So we might want to review that with her as well. So the Mylanta is not relieving her symptoms, so she gets new orders. And one of those orders is the urea breath test. Now, this is just kind of a fun fact. It's not You're not going to be tested over this, but a urea breath test is the patient is given a urea tablet that is bound to a carbon, which then reacts with Helicobacter pylori, or H. pylori, which is a bacteria that can live in the acidic environment of the stomach and frequently is the cause of ulcers. So this reaction of the carbon and the urea with the H. pylori causes the carbon to be exhaled due to the breakdown of the urea by the bacteria. So they breathe into something and it will label that. Now, they can also do blood work to establish the presence of the H. pylori as well. So if they are found to have H. pylori, then they will be given antibiotics for a couple of weeks to take care of the bacteria. So that's why the order for the ampicillin and the erythromycin, both of which are antibiotics that you probably recognize. The tidine, the ranitidine, it reduces the acid production, which allows for healing. And then the sucralfate is a coating agent. Notice that it's given before meals and at bedtime. So when the patient takes the sucralfate, it forms a layer over the ulcer, allowing it to be protected from the acid in the stomach so that the ulcer can heal. So I want to back up just a second and ask you, what is the result of reducing the acid production? Besides that, it allows healing. What happens to the pH in the stomach when the acid production is reduced, or when they take an antacid which neutralizes the acid? So hopefully, real quick in your mind, you popped up with the answer that the pH will increase. So the goal of treatment is to increase the pH to reduce the production of the acid, or to get rid of the H. pylori, or coat the ulcer, all in an effort to allow healing. So the tidines are H2 receptor antagonists. So the histamine 2 is produced, but if it doesn't bind with its receptor, then we don't get the acid production. So ranitidine and, oh my God. Sorry, I had an alert pop up from Neosho County that I didn't know if it stopped my PowerPoint, so I apologize for all this extra discussion. Anyway, so ranitidine, cimetidine are all examples of the tidines. Dizziness can be a side effect, which of course would mean that we would have safety issues. It can lead to confusion. Different people respond differently, and some may have diarrhea, some may have constipation. Hepatotoxicity is a concern, so it can be toxic to the liver. Uh, the tidines should not be taken at the same time as an antacid. Uh, it can be taken with or without food. And one of the main things we want to teach patients um, is that it's going to take time to see results. They're not going to feel better after one tablet. They may not feel much better after a week. It can take 4 to 8 weeks with the tidines for the ulcer to heal, and they should see gradual improvement in the symptoms, but they may continue to have symptoms for quite a while. Um, if the tidine is ordered only once a day, it should be given at bedtime. Sometimes they're used not just in the treatment of ulcers, but in the prevention of ulcers. So it might be given when a patient is NPO postoperatively, or they have an NG tube, so that the acid production doesn't cause an ulcer. So how are you going to know that, or how will the patient know that the tidine, such as Zantac, is working for them? Well, obviously they should see a decrease in and eventually a complete lack of symptoms. What are the symptoms? Heartburn would be one. Reflux, epigastric pain might be one. So, that's what, whatever their symptoms are, they should start seeing those decrease over time. Sucralfate is a coating agent, so it needs to be given on an empty stomach. It should be given an hour before meals and at bedtime on an empty stomach. It may cause constipation and dry mouth. And if a Prazole is ordered, and the Prazoles are the proton pump inhibitors, then it should be given 30 minutes after a Prazole. So the tidines and the Prazoles are both inhibit the production of the hydrochloric acid, which is, of course, is the stomach acid that's causing the damage. Omeprazole, which is Prilosec, is an example of a Prazole. Again, they're proton pump inhibitors. They can cause diarrhea. If a rash develops, the patient should contact the healthcare provider and stop taking the medication. Best if taken on an empty stomach before a meal. It doesn't matter if it's morning or evening, but just on an empty stomach. 30 minutes to an hour before a meal. And the Prazoles have the advantage of working a little bit faster. So the patient should start to see improvement within 2 to 4 weeks. So we've addressed the issue of the ulcer, and we want to now address the constipation. So we're going to assume that there isn't any pathology that's causing the constipation. So she doesn't have any blockage. She was passing gas. She has good bowel sounds. All of the assessments are okay. So we need to determine which laxative option would be good for this patient. And if it's not good for this patient, who would it be good for? So let's look at stool softeners. Stool softeners are Ducosate sodium or Dulcolax. It can also be Ducosate calcium. Stool softeners work by pulling fluid into the feces. They do not stimulate peristalsis. So usually we say that It doesn't make you go, it just makes it easier to go. So they're considered gentle, but it may take 72 hours to see results. So they would probably be good option for this patient. It's also good for pregnant women who become constipated because of the weight of the uterus. It's good for patients taking iron supplements because iron is constipating. Good for people who are instructed not to strain, like people with hemorrhoids, people post MI or myocardial infarction, heart attack. Um, or just people who want to try to have some type of regularity. Now, osmotic laxatives like lactulose pulls large amounts of fluid into the feces. So the stool softeners just pull in a little. Osmotics pull large amounts of fluid, and they stimulate peristalsis, causing a BM. And they do this because of the volume of fluid increases the bulk of the stool. They're typically only for short-term use. Sorry. Short-term use in the cases in a case of acute constipation, or maybe to be used as a bowel prep before a procedure. Lubricant laxatives lubricate the bowel wall, again making passage easier. They also do not stimulate peristalsis. They're also good for constipation in pregnancy, constipation due to diet changes, or again the iron supplementation, or changes in activity. Someone has gone from an active lifestyle to a more sedentary lifestyle, they're going to experience some changes in their bowel habits. Bulk forming laxatives like psyllium increases bulk. That's why they're called bulk forming. So the increased bulk is going to stimulate peristalsis. Bulk forming laxatives usually work within 24 hours. They do form a soft, easily passed stool as long as they're taken with adequate fluids. Now, if they're not taken with adequate fluids, then they actually can cause a harder mass of feces, which is much more difficult to pass. So, what does that tell you then? That is a nursing consideration or a patient teaching. We've got to make sure that people are taking it with adequate fluids. Bulk forming laxatives are good for incapacitated patients who need a laxative to promote regularity. So this might be someone with spina bifida, someone with a spinal cord injury, end-stage Alzheimer's, people who are bedridden, who have very little muscle tone or little activity. A stimulant laxative irritates the bowel wall, so of course it's going to promote peristalsis and should be used very sparingly because they can cause dependence. Meaning the patient won't be able to defecate without using a laxative. Stimulant laxatives, and this is just kind of a side note, actually destroy the villi in the bowel wall and interrupt the reception of the nerve signals that stimulate peristalsis because the body becomes so reliant on the laxative. So we talked a little bit about things we wanted to ask the patient before we would decide to use a laxative or not. So what would be some of the things that would cause us to say no, a laxative is not a good choice for you? And one of these would be if they're not passing gas, then that tells us maybe they have an ileus. Um, the bowel is actually not working. Um, if they are passing, they haven't had a stool for several days, but now they're having the just liquid stools, might mean that they have an impaction. Um, and uh, further testing might be needed before a laxative is prescribed. Or perhaps enema would be the preferred method of cleansing. If they have appendicitis or any abdominal pain of unknown origin, um, if they have, if they're distended and they're having discomfort from that, that's one thing. But if they're having pain that is unusual, or doesn't seem to be related to the constipation, then a laxative may not be the thing to do. Um, so metoclopramide, uh, metoclopramide wasn't ordered, and metoclopramide is the trade name is that you might be familiar with is Reglan. It is typically given for PUD, peptic ulcer disease, and GERD, gastroesophageal reflux disease, that hasn't responded to other medications. Well, our patient hasn't been on any other medications, so we don't know if she's going to respond or not. So we're going to try those other meds first. So what is metoclopramide? Metoclopramide is considered a prokinetic, meaning that it promotes emptying of the stomach by causing the stomach the stomach peristalsis to increase and the stomach contractions to increase, so that um, uh, the stomach empties faster. It also increases peristalsis of the bowel. So for this reason, um, it's used for PUD and GERD to prevent reflux, because the faster the stomach empties, the less there is to wash back up into the esophagus. Um, and the hydrochloric acid that is being produced is emptied faster into the duodenum, as opposed to sitting in the stomach and being allowed to wash up. So it prevents reflux, and by emptying the stomach, and then the reflux that does occur has less acidic, uh, less acid. It doesn't change or impact hydrochloric acid production at all. It just causes it to be emptied out faster. Now, metoclopramide can also be used for nausea, um, nausea of chemo, postoperative nausea, and again, it does that by promoting emptying of the stomach. Um, it's also sometimes given just to reduce, if you remember about anesthesia, or maybe you don't know this, I don't know, actually. Um, Anytime a patient undergoes general anesthesia, especially, the bowel slows down. And then if they've had abdominal surgery on top of that, any manipulation of the bowel, um, physical manipulation, will cause it to stop working. So they often will give the metoclopramide or Reglan postoperatively in order to um, promote resumption of bowel function. It can be given PO or IV. If it's given PO, it should be given before meals, and at HS. Typically, if it's given for PUD or GERD, uh, the patient has already tried lifestyle and diet changes that didn't work, and other meds that didn't work as well. So, metoclopramide is not the first line of defense for PUD or GERD. Now, one of the disadvantages of Reglan or metoclopramide is that the side effects are extrapyramidal symptoms, similar to Parkinson's disease. So this would be uncontrolled movements like tremors of the hands, restlessness, muscle spasms. Um, so it's not a good option for Parkinson's patients or patients taking other extrapyramidal symptom type drugs, stimulating drugs like the phenothiazines, like compazine and promethazine, which are drugs that are frequently given for nausea. So you wouldn't ever give those two drugs together. Because of the promotion of stomach emptying and peristalsis, there is a risk for hypoglycemia because things aren't going, carbohydrates aren't going to break down as quickly. Sorry about that. So there is a risk for hypoglycemia. We're also not going to give metoclopramide, just like we wouldn't give a laxative, something that stimulates peristalsis, to a patient that has a known obstruction, abdominal pain, or appendicitis. All right. So now we're going to address the opposite of constipation, which is diarrhea. And anytime a patient complains of diarrhea, we again need to get some history to determine what the cause of the diarrhea might be. The other thing to keep in mind is that as distressing as diarrhea is to people, it usually is a symptom of something else. And one of the things that we have to be concerned about, and again, not testing you on this, but I just think you need to understand it, is that it's often a side effect of perhaps some type of toxin. So stopping the diarrhea is not always the best thing to do. The best thing is to just make sure that the patient is hydrated, and they're keeping fluids down and they're replacing the fluid that they lose. And then, of course, we always run the risk of acid-base imbalance with prolonged diarrhea, but that's a whole nother story. But I just think that as a nurse, you should know that just because someone has diarrhea doesn't mean that we automatically need to give them something to stop it. But so first, we're going to ask them some questions to determine what the patient needs to do. So some of the things we want to know is duration. How long has it been going on? If it's a day, let's write it out. If it's a week, then maybe you need to see somebody about that. How frequently are the stools occurring? Are you having one loose stool or liquidy stool a day? Deal with it. Are you having 10 liquid stools a day? Maybe we need to deal with, address that. What are the characteristics of the stools? Um, are they just water? Are they really just loose stools as opposed to diarrhea? Because honestly, diarrhea is fluid loss. It's not just increase in frequency. It's not uh, um, an increase in or decrease in thickness or firmness. Some people just sometimes have softer, looser stools, and that's okay. Um, but if they're liquid, then that's diarrhea. So what are the characteristics? Is it foul smelling? What color is it? Is it dark? Is it light? Is it just clear water? What does it look like? Is there any pus? Is there any foreign matter? Um, does it smell bad? What exactly is going on? Is it accompanied by nausea and vomiting? Are they experiencing cramping? And then we also want to address possible causes. Are they on antibiotics? Because if they are, we definitely don't want to treat it without investigating for pseudomembranous colitis. Again, not testable, but I just want to throw that out there at you. Have they traveled outside of the uh, United States recently? Are they taking any other medications that might be causing the diarrhea? So, if they are, if they have recently traveled, if it's been over a week that they've been experiencing the diarrhea, if it's foul smelling, accompanied by nausea and vomiting, um, if they look dehydrated, these might be reasons that they need to seek um, further health care. Um, if it's just because they change their diet at home or something, then they could possibly treat it. But the main thing that we would want to tell them first is lots of fluids and foods that are going to absorb that fluid, but yet not irritate the gut. So let's not have a lot of spicy food um, or foods that are more irritating to the bowel. So uh, there are different types of antidiarrheals, and some are centrally acting, meaning they actually um, act within the brain to um, exert their antidiarrheal effect. So there's diphenoxylate, um, which, and actually you can get most of these over the counter. Diphenoxylate uh, should not be taken with MAOIs. It does not contain a CNS depressant, nor does it have CNS depressing effects. Loperamide, also known as Imodium, has no known drug interactions. If they start taking these and they don't see results within 24 to 48 hours, or the diarrhea begins to get worse, they just need to see their healthcare provider. So antiemetics, obviously against emesis. So we're going to look at these 4 reasons for need for antiemetics and discuss which antiemetics might be most beneficial. So postoperatively, we can use the phenothiazines, such as prochlorperazine, which is compazine, or promethazine, which is Phenergan. These are dopamine antagonists, so they are useful for post-op. They don't um, they just a minute, let me rethink this for just a second. What I'm really trying to say is they do have some sedative effect, which isn't always bad, especially if you're nauseous. You sometimes just want to take a nap. Um, because of their actions, they can cause hypotension. Um, so taking the blood pressure prior to administration, or knowing what the most recent blood pressure was, is a good nursing action. The dopamine antagonists like prochlorperazine and promethazine can be given IM, PO, rectal, and even IV. Um, so you want to consider the best route for the patient who is actively vomiting, depending on the situation. Obviously, if they are in the hospital and they have an IV, well, let's give it IV. But if they don't have an IV, then maybe IM or rectally might be better options. Ondansetron, which is Zofran, is a serotonin antagonist, and it's also useful for post-op, but primarily Zofran or ondansetron is used for chemo-induced nausea and vomiting. It used to be Zofran used for pregnancy, but recently there's been I guess it's not real recent, but it's all relative. So 10 years ago we used it. Now we don't use the Zofran for pregnancy because of the presentation of birth defects that have occurred with it. So primarily Zofran or ondansetron is used for chemo, but it can also be used for post-op and in the case of bowel obstruction. Pregnancy, the dopamine antagonists, prochlorperazine and promethazine, can be used. You can also use antihistamines or anticholinergics, such as diphenhydramine, which you'll recognize as Benadryl, diphenhydramate, and promethazine, because promethazine has the anticholinergic side effects, which cause dry mouth, tachycardia, but it also reduces nausea. So they can be used for motion sickness, pregnancy. They can be used post-operatively and even for chemo, but they're not as effective. So now we're going to talk a little bit about some endocrine disorder medications. So we've got a type 1 diabetic who's been given some information about different combinations of insulin, and they are trying to decide what would work best for them and their lifestyle. So the first thing the patient wants to know is how insulin helps to control blood sugar. And I know we haven't really talked about diabetes yet, but every cell in the body uses glucose for energy. Most cells require insulin to carry the blood sugar into the cell. Now, the Exceptions to that rule is the brain, and the brain uses a huge amount of sugar. The liver and the kidneys don't require insulin to utilize the sugar, but the rest of the body requires insulin to open the door of the cell, as you will, in order to allow glucose to enter. So when glucose is circulating around in the blood without insulin, the cells don't know that there's any sugar available. So insulin then moves or promotes the movement of glucose from the blood into the cells. So insulin opens the door that allows sugar to move in. So in order for the patient to make a decision, an informed, educated decision about their insulin use, you need to know things about the insulin to teach them. So you need to know the types of insulin. Is it rapid, short, intermediate, or long? You also have got to know the onset, the peak, and the duration of each insulin. And can it be mixed? So our patient has the option of using Aspart or Lispro with NPH in the morning, Aspart or Lispro at noon, and then NPH in the evening. Or our patient can use regular insulin 3 times a day with Glargine at bedtime. So the first thing we need to know is what type of insulins are these. So Aspart or Lispro are both rapid-acting regular insulins. So what does it mean to be a rapid-acting insulin? So they onset in 10 to 15 minutes. They peak in 1 to 3 hours, and they last 3 to 5 hours. So what does that mean for you and your patient? One of the things that means is that the meal has to be ready, and the patient has to be ready to eat within that 10-minute window of this Aspart or Lispro starting to work, so that their blood sugar doesn't start to drop before they've got something in their system, food in their system. So Aspart or Lispro, and you're going to need to know this for the test, which is which. So Aspart or Lispro are the most rapid acting. They have the shortest onset, they have the shortest time to peak, and they have the shortest duration. NPH is an intermediate acting insulin, usually designated with an N on the label, and it's usually cloudy. Regular insulin and long-acting insulins are clear. Regular insulin especially is always clear. Intermediate or NPH insulin onsets in 1 to 2 hours. Now think about that. What is the peak for the rapid? So we've got a patient that's going to get Aspart and Lispro, one of these two rapid acting with the NPH. Now the rapid acting starts very quickly, but when does it peak? It peaks at 1 to 3 hours. When does the NPH start? 1 to 2 hours. So what's going to happen at approximately that 2-hour mark after the insulin is taken? You've got one starting to work and one peaking, doing its most good at that time. So this is the time when the patient's blood sugar is the most likely to be low for this combination. And that's why you need to know what kind of insulin they're getting, and when does it start, and when does it peak, and how long it lasts. Because if there's any overlap like that, that's the time when your patient's blood sugar is going to be the lowest. NPH insulin is intermediate. It onsets in 1 to 2, peaks in 4 to 12, and can last 16 to 24 hours. So if we look at this for this patient, so they're going to take the NPH and the rapid at the same time. The NPH starts when the rapid peaks, and the rapid is ending at about the time that the NPH peaks. But it's also about the time that they're going to take another dose of the aspart or the lispro. So they need to make sure that they're eating the noon meal, because that is when the NPH is going to be doing its most good. And then they take another dose of NPH in the evening to keep them through bedtime. The other option for the patient is to take regular 3 times a day and glargine at bedtime. Now, regular is considered a short-acting. It's not quite as fast as the aspart or the lispro, but it's faster than the NPH. So regular or short-acting, designated with an R, always clear. It can be given IV. Starts to work in 1/2 to 1 hour. Peaks at 2.5 to 5 hours. And lasts 5 to 10. It can be mixed with NPH. But it's always drawn up first. So you can mix, if you think about it, NPH is always cloudy. Regular is always clear. You always drop the clear first. It's clear to partly cloudy. Glargine, then, is a long-acting. It actually lasts approximately 24 hours. It starts to work in about an hour, but it doesn't have a peak. So it starts to work and then it just levels off. It cannot be mixed with any other insulin. So really the only ones you can mix are regular and NPH. Never going to mix anything with glargine. So with the second option, the patient's blood sugar is going to be at its lowest about 3 to 4 hours after the patient takes it. And then that glargine is going to be working all day, through the night and all day, because they usually take the long-acting at bedtime. Because a lot of patients with diabetes will have a spike in their blood sugar at night. Even though they're not eating, it's just one of those physiologic nuances that occurs. So you want to know which insulin does what. So when does it peak? When does it onset? When does it peak? How long does it last? What you can be mixed with. So now we have a type 2. Now, with type 2 diabetes, there's some insulin production continuing. With type 1, there's no insulin, and they have to have insulin to live. With type 2, we can use other medications to lower the blood sugar without necessarily using insulin. So this patient's being prescribed a sulfonylurea, which is glyburide or glypizide. So you can kind of see sulfonylureas begin with gly as opposed to ending with something. Anyway, because they are essentially a sulfa-based drug, any patient that is allergic to sulfonamides would want to use sulfonylureas cautiously, or maybe use a different drug altogether, depending on their sensitivity. Sulfonylureas need insulin to work. So the patient has to be producing insulin in order for the sulfonylureas to work, because they stimulate the production or the release of insulin from the pancreas. For that reason, because they do increase the secretion of insulin, they may cause hypoglycemia due to an overproduction of insulin. Patients need to know that they may have low blood sugar. They need to know what the symptoms of low blood sugar are, which you don't need to know right at this moment, but that would be another point of teaching. Sulfonylureas are best taken before the primary or largest meal of the day. So that doesn't mean that they have to be taken at breakfast. They can be taken at lunch or at supper. But if they're taken just once a day, it should be before the primary meal of the day. Meglinotides also require insulin to work because they stimulate the pancreas to secrete insulin as well. Really, all the oral hypoglycemics require insulin to work. They just need it for a different reason. So the sulfonylureas and the meglinotides stimulate production or release of insulin from the pancreas. The biguanides increase the sensitivity of the cells to the insulin, because one of the problems in type 2 diabetes is insulin resistance, so that the cells just fail to recognize that insulin is okay to open the door. So they've reset the code. They've changed the numbers, so insulin can't open the door. So biguanides reset the code so that insulin can get in, bringing the sugar into the cell. Biguanides also decrease production of glucose by the liver. So if you weren't aware, the liver does produce sugar, which is not always helpful, but it's kind of one of the underlying factors in metabolic syndrome, probably. And again, not testable. I'm just telling you, just talking, aren't I? But stress reaction is going to cause that release of glucose, because your body thinks, oh, I need to fuel for this stressful situation, and when in fact we don't need it, because we're taking in enough fuel because we're stressed. But anyway, so with biguanides, we typically will not see hypoglycemia when used alone, because we're not increasing the insulin production. But we may see hypoglycemia if the biguanides are paired with the sulfonylureas or the meglinotides, which is often done because they have different mechanisms of action, so we have the potential to have better glucose control. The nice thing about biguanides is that we won't see weight gain. The disadvantage is that they are usually taken BID, and so patients frequently, anything we have to take more than once a day, it's sometimes difficult to remember that second dose. And remember, frequently patients with type 2 don't feel bad. Um, they don't feel sick, especially, and so it's easy to think, oh, I don't really need that second dose because you can't see the effects right away of the high blood sugar. It should not be taken by patients with renal or liver disease, or if they're undergoing a procedure with radiopaque dye. So it needs to be held for 24 to 48 hours if they are going to have a CT scan or an MRI or renal pyelogram, anything that uses radiopaque dye. GI side effects are the most common, so they can take it with meals to reduce that. And a severe side effect of biguanides is lactic acidosis. Now, usually with diet, exercise, and the oral hypoglycemics, type 2 diabetics can control or maintain their blood sugar within relatively normal limits. However, in times of illness, stress, surgery, trauma, whether it's mental, emotional, physical stress to the body, there again is that increased production of glucose as the body thinks it needs more fuel to heal. And so we end up having poor control of the blood sugar with the oral medications. So sometimes, more often than not, the patient will need insulin during that time of stress to decrease their blood sugar until they recover. It doesn't mean that the patient will be on insulin now for the rest of their life. Usually by the time they are ready for discharge or their illness is over, then they no longer need the insulin. So they're usually not going to be discharged with the insulin. Sometimes, depending on the illness, they might be. Thyroid disorders, we have levothyroxine, which is Synthroid. It is obviously used, we're replacing the thyroid hormones T3, T4. So it's used for hypothyroidism. In hypothyroidism, the thyroid gland is not producing the hormones, so we have to replace them. And so levothyroxine is a synthetic thyroid hormone. It works by acting like the thyroid hormone in the body. So anything that the thyroid hormone naturally would do, that's what the levothyroxine is going to do. So it's going to increase the metabolism, which will regulate body temperature, regulate body weight. It affects everything from condition of the hair and nails to appetite, environmental temperature perception, all of those things. So by understanding what the thyroid does and what the thyroid regulates, then we can understand what we would expect with hypothyroidism. Metabolism slows, which means weight is gained. It means the body temperature falls. It means that the patient is more susceptible to cold temperatures, I guess. They feel cold in temperatures that other people don't feel cold in. They're frequently irritable, lethargic. They're tired all the time. I mean, their body just doesn't have any energy because it's not being utilized appropriately without the thyroid hormones. So how will we know then that the levothyroxine that we're giving the patient is working? Well, we should start to see reversal of all of those symptoms. So they may start to lose weight. They should have better temperature control. Their heart rate will come up. They, won't feel cold. Um, did I say heart rate already? I don't remember. But heart rate is a good quick way for nurses and patients to evaluate whether the dosage is accurate or adequate. Um, of course, as long as nothing else is going on. So typically, heart rate will fall with hypothyroidism. Once we start taking the thyroid medication, levothyroxine, the heart rate should start to climb. Um, it should still stay within normal limits, but it should be slightly faster. So how will we know if the dosage is too much? So we started out with a patient who was overweight, lethargic, cold, low blood pressure, low pulse rate. We give them too much thyroid hormone, and they're going to start to lose too much weight. They're going to be sensitive to heat. Their heart rate is too high. They're not resting well because they have all of this, not necessarily productive energy, but energy. So we're just going to see just the opposite of what they saw before. So we need to teach the patient, besides the symptoms of that it's working and what's the symptoms of too much, we also want to tell them things about the medication, how to take it. They need to take it in the morning before breakfast, so it should be at least 30 minutes before breakfast, or before their earliest meal of the day, perhaps, because everybody works different schedules. Should be taken on an empty stomach. It needs to be taken daily at approximately the same time every day. They will need to have blood levels monitored, typically on a monthly or even less frequent schedule once they have been on it for a while. They also might not need to know that their blood sugar, if they're diabetic, may increase as their body responds to the new metabolic needs. Now, patients with hyperthyroidism have the opposite problem. With hypo, they're not producing enough. With hyper, they're producing too much thyroid hormone. So everything is out of whack. Their blood pressure is elevated, their pulse is elevated, their reflexes are hyper responsive. They're typically thin. They have too much energy. They can't stand the heat. But and even if they're eating well. So somehow we've got to get rid of that thyroid hormone. And the only way to do that is to get rid of the thyroid. So we have a couple of medications that will either destroy thyroid tissue or stop production of the thyroid hormone. So iodine 131 is a radioactive iodine. Now, why does this work? It works because the thyroid requires iodine to do its job. So it's especially sensitive to iodine. So we give the radioactive iodine, the thyroid gland soaks up that iodine, and the radiation will kill the gland, destroys the thyroid tissue. So obviously we destroy the tissue, then we stop production of the thyroid hormones T3 and T4. If we destroy too much thyroid tissue, now the patient goes into a hypothyroid state, and they have to start taking Synthroid, which is kind of weird, but it does occur. The other medication is that we want to talk about, and your book talks about more, but this is all we're interested in today, is propylthiouracil, or PTU. And I just like saying propylthiouracil because it looks like it's a really hard word, but it's just kind of fun to say. So PTU actually stops the thyroid from producing the hormones. And if the dosage is correct, the patient will develop what we call a euthroid or normal thyroid state, and they won't be either low and they won't be high. Okay. Now we have a patient with Addison's, and Addison's is a disorder of the adrenal gland where the aldosterone isn't working appropriately, and so the patient is constantly losing sodium, and of course we know that water follows sodium, so they're losing fluid as well. So they have a very low blood pressure, and they're constantly drinking to maintain their fluid balance. So they have a low blood sugar or blood pressure. Sorry about that. So we have to replace that hormone, and we do that by giving a mineral corticoid called fludrocortisone. So the purpose of the medication is to cause the body to retain sodium and thereby retain water, which helps us then to obtain and maintain blood pressure control through adrenal hormone balance. The patient will need to know that because now they run the risk of retaining too much fluid, they could experience edema. They could experience hypokalemia as a side effect because of retaining sodium, so now they might be getting rid of potassium. So they need to know what the symptoms of hypokalemia are, which are weakness, fatigue, muscle cramps, constipation. And they also have the potential for acid-base imbalances because of the potassium and hydrogen ion loss. Now, fludrocortisone, depending on the, not necessarily with Addison's, but other adrenal gland disorders, that's where our cortisone, our steroid hormones are made, is in the adrenals. So sometimes we have a problem where it's not just the mineral corticoids and it's not just the glucocorticoids. It might be both. So we have to give a glucocorticoid as well. And you might be familiar with glucocorticoids in that they are what is frequently used to reduce inflammation. So patients with asthma or COPD or pneumonia might be given a glucocorticoid to reduce the inflammation associated with those things, or cellulitis or any other inflammatory disorder. And glucocorticoids are anti-inflammatory because they alter the immune response. So it's important that anytime a patient is taking a glucocorticoid, that they are given adequate instructions. Again, glucocorticoids affect sodium and fluid, so we may see edema. They might want to avoid salt. They can cause an increase in blood sugar because, after all, that's what cortisol does. Because they alter the immune response, glucocorticoids may mask signs of infection and slow wound healing. They frequently cause easy bruising because they cause the capillaries to be fragile. And they can cause gastric acid production, which increases the risk of peptic ulcer disease, or PUD. And they can take that with food in order to reduce gastric acid, gastric irritation is what I wanted to say. So a lot more about glucocorticoids. And then the other big thing is that patients taking glucocorticoids, and this is like your prednisone or your Medrol dose pack, should never stop taking them abruptly. Because the adrenals, like the kidneys, they're not the smartest organs in the body, and they're kind of lazy. And once they realize, hey, someone else is doing our job, we don't have to, they stop. They'll stop producing the glucocorticoids. And if we stop taking them abruptly, the kidneys are kind of slow to respond, and then the patient is going to be in adrenal crisis. So it's important that they understand that. Hormone replacement or hormone use in women. Typically, we think of hormone replacement as a treatment for menopause. We can also use hormones for birth control or for certain cancers. Women should know that any type of exogenous hormone, whether it's used for menopause or oral contraceptives, increase the risk of heart disease, increase the risk of clots, and may cause unusual vaginal bleeding, which means that it should be stopped. So women who are sedentary, who have a high risk for heart disease, have had previous clots, who smoke, should not use oral contraceptives or hormone replacements. And then BPH is benign prostatic hyperplasia. One of the medications for treatment is finasteride, which is an androgen hormone inhibitor. And an androgen is just a fancy name for male hormones. So we inhibit the male hormone, which relieves the symptoms of BPH. And the primary symptom of BPH is urinary retention, difficulty starting the stream, a low flow stream. It works by reducing the size of the prostate, and it's also used for male pattern baldness. I know, interesting. The dosage is different. It's a much higher dose for BPH than is used for male pattern baldness. Patient teaching for finasteride. Women who are pregnant or are childbearing age should not even look at it. They shouldn't touch it. They shouldn't even look at it. So if you have to give it, make sure you wear gloves to handle the package, to open the package, to give it to the patient, because it can cause severe birth defects. One of the disadvantages for the man is that it can give false negative results on a PSA, which is the prostate surface antigen, which is an indicator of prostate cancer. And it may take 6 to 12 months to see therapeutic effect of the drug. Now, most of the time on the tests, we try to give you the name of the drug and what the drug is, what kind of drug it is, So like omeprazole, a proton pump inhibitor. But there's some of them that if we tell you what it does, such as lactulose a stimulant laxative. If we tell you that, it gives away too much information. So there are some questions that won't tell you what kind of drug it is. So this unit, more than any of the others, you do need to know some of the drug names. So I've tried to include those when appropriate, or when I could remember. So I apologize that this is so long, but I do hope you find it useful.